The ISUOG updated guideline 2025. This is the recent 2025 guideline. Okay, 2025 recent guidelines. The role of ultrasound in twin pregnancy. What are the recent recommendations? The basically the outline of this guideline is you have to know the how to dating about dating of the pregnancy due to the gestational age, due to the chronicity, amnicity, twin labeling, timing, frequency of ultrasound assessment, screening of aneuploidy, prenatal diagnostic for aneuploidy, screening structural anomaly, and diagnosis management discordant twin pregnancy, fetal reductions, and select terminations, risk of preterm birth, diagnosis management FGR, management twin pregnancy, complicated by single IUD, complication unique to monochorionic twin pregnancy, like screening tests like diagnostic staging management twin to twin transfusion syndrome, screening and diagnostic management TAFs, and management TRAF sequence management MCDA, MCMA twin, and management conjugate twin. So basically the past is the recommendations. Basically I will the overview, then we'll start with the recommendation dating of twin pregnancy. So basically that they are telling the dating should be always start from the dating should be. So basically the twin pregnancy, the dating should always if the pregnancy is conceived spontaneously, the should ideally the dating should be dated prior to less than 13 plus 6 weeks gestational age. Okay, and the in twin pregnancy, if they conceive spontaneously, the larger of the twin, if you get if they conceive spontaneously, if you get two twins with the larger CRL, you have to take the larger CRL of the twin for the estimated gestational age if they conceive spontaneously. And another things, if they can and second things is you can take the, if the patient came before 40 weeks, the CRL, very important statement they told here. Actually they told if it is less than 14 weeks and they conceive spontaneously, you have to take the, you should date before 14 weeks. But if they come before 14 weeks or more than 14 weeks, if they come more than 14 weeks or less than 40 weeks, if they came before 14 weeks, the you should take the CRL of the larger twin. Okay, larger twin CRL you have to take. If they came more than 14 weeks, then you have to take the fetal head circumference to get a fetal head circumference to get the gestational age. Okay, so fetal head circumference of the larger twin, same things. Okay, always take the larger twin ka head circumference. So basic principle is, if the patient is conceived spontaneously, first statement, the patient conceived spontaneously, should ideally the dated should be done prior 13 plus 6 week gestational age. And another things, if this conceived spontaneously, if they came less than 14 weeks, ideally should the less than 14 weeks. If they came less than more than 14 weeks, then you take the head circumference of the fetus of the larger twin. If they came before 14 weeks, then CRL of the larger twin has to be taken for the correction of the gestational age. Okay, the second statement, the first statement here is the, if they conceive spontaneously or if they didn't conceive spontaneously. If they conceive by in vitro fertilization, then you should take the age of the embryo, or you can take the date of embryo transfer to you get the correct gestational age, date of embryo transfer. Okay, and the reason behind is, if you take the smaller twin CRL, the smaller CRL is the potential for the operator that there will be a discordant phase. The larger twin, they thought the larger twin will be grow as per gestational age, and they will falsely reassure that the smaller twin is grow proportionately. But they've seen if they took larger CRL, they will not increase the proportion of neonatal class by SGA. So, choronicity should be determined prior to the theme 13 plus 6 week gestational age, as many ultrasound characteristics as possible. Basically the chronicity and amnicity, you have to include many ultrasound characteristic, like your entire intertwin septums at the site of insertion of the amniotic membrane into the placenta, using the lambda signs or the T signs, the membrane thickness you have to measure, number of placental mass you take, and image has to be saved, kept in the medical records. Here another thing is, in monochorionic in pregnancy, the amniosity actually it can be determined from 8 weeks onwards. So when you get two amniotic sac in monochorionic twins become visible ultrasound, so you have to refer early. And the labeling of twins should be follow a reliable, consistent strategy, should be documented in the clear woman's notes. Twin fetus should be based on the lateral and vertical orientation of the fetus of the gestational sac, including as many as parameters as possible. And there will be the routine monitoring. Already told, on complicated twins you have to the should be done first trimester, then second trimester alimony scan, then scan every 4 weeks. If it is complicated, depending on the situation, you do. Uncomplicated monochorionic twins should have every 2 weekly. From part 11 to part 16 weeks onward, you will start to prevent detect twin to twin transmission syndromes. Now they told the screening for chromosomal abnormality in twin pregnancy. The screening for trisomy 21 in twin pregnancy, this should be offered in the first time. The most accurate test that is can be offered from 10 weeks gestation is use cell-free DNA in the maternal blood. The detection rate is positive prediction rate is NIPT trisomy 21 is slightly lower than twin in singleton in twin compared to singleton, but it is the most, now they are telling this is the most accurate method, that is the NIPT for screening of trisomy in twin pregnancy. But data is less insufficient, limited data is there, but they are telling this is the most accurate test for screening in trisomy 21 for first time. But if in the setting where if you're not getting NIPT is not available, in that time you should do knockout combined test, that is NT plus beta SC, free beta SC plus PAP A label, and alternative combinations is you go for a maternal AS plus NT depending on the clinical context. In the suppose if there will be a vanishing twin syndrome, suppose it's a vanishing, then in that case you just do NT plus maternal AS, NT plus maternal AS. Don't do the both beta SSC dual marker. Here you have to do a single test, that is pre beta SSC level only, because in vanishing twin the serum PAP A level is already increasing level, so it will give a wrong report. So first the screening, basically screening NIPT is the best. The statement, if you summarize this statement, the NIPT is the most accurate test, and if it is NIPT is not available, then go for NT plus dual or NT plus age, or if it is a vanishing twin, then you do NT plus pre beta SZ level only. Okay. Then another statement, like the diagnostic, basically the diagnostic test, they told CVS is more preferred in twin pregnancy compared to the amniocentesis, because you will get a earlier report, because you get a earlier and prenatal diagnosis. If in a MCD twin pregnancy complicated by discordant anomaly, the options of dual amniocentesis should be considered. If there will be a discordant in the anomaly, suppose one baby has different anomaly, another baby has a different anomaly, then you have to go away, different dual amniocentesis should be considered. And the indication of discordance in implication, what are the implication of NT discordance or CRL in the first trimester twin pregnancy? The twin pregnancy CRL discordance more than 10%, CRL more than 10%, or NT discordancy is more than 20%, then you have to refer to fetal medicine centers. And basically the ultrasound screening for structural abnormality in twin pregnancy, the twin fetus should be assessed for the presence of any other major anomaly at the first trimester scan, and the routine second trimester anomaly scan should be performed at around 20 weeks. But very, very important statement, in monochorionic twin you should go for a fetal echo. Okay, fetal cardiac assessment should be done in monochorionic twin pregnancy. Okay. The managing twin pregnancy discordant for fetal anomaly, twin pregnancy should be referred to fetal medicine centers. Selective feticide in twin pregnancy, in dichorionic twin pregnancy, the selective feticide is performed by ultrasound guided intracardiac or intrafunicular injections. Funicle means at the level of umbilical incisions. Potassium chloride injections, KCl or lignocaine you inject to do a, preferably always do feticide in the very, very important statement. Basically, if you do first trimester, the chances of fetal loss is very less, so you should go for a first trimester. Selective feticide is should perform ultrasound guided intracardiac intrafunicular injections of potassium chloride or lignocaine, preferably in the first trimester. When diagnosis is made in the second trimester, suppose the patient came later in the second trimester, the woman might you can opt for a late selective terminations in the third trimester if the law will permits. Okay. The selective feticide in monochorionic twin pregnancy is performed by, basically in the dichorionic you go for a intracardiac ultrasound guided intracardiac or intrafunicular injection of KCl or lignocaine injections. So basically if you divide, it is a monochorionic or dichorionic. The dichorionic, you go for a intracardiac injections of KCl or lignocaine or intrafunicular injections. If it is a monochorionic, then you go for a laser ablations, a cord occlusion, laser cord occlusions, or intrafetal laser ablations, or microwave ablations, or radio frequency ablation. So basically, if you divide this, if you do a selective feticide in the twin pregnancy, if it is a dichorionic pregnancy, okay, if it is a dichorionic, then usually you should do first trimester, or if is law permit, then second trimester or third trimester, you can give intracardiac or intrafunicular injection of KCl or lignocaine. If it is monochorionic, intrafetal laser ablations, cord occlusions, or microwave ablation or radio frequency ablation procedure can be done. Selective feticide reductions. Okay. The next thing is the screening for risk of preterm birth in twin pregnancy. The cervical length measurement, ideally you should go by transvaginal route methods. Preferred method for screening preterm birth. Basically, you have to do from 18 to 24 weeks, and the preterm birth in the 25 mm is the pragmatic cutoff between 18 to 25 week gestation is. The cervical length should be measured at the anatomical scan, that is an anomaly scan. If there will be an additional risk factor, the first, basically they are telling, if you do a cervical length measurement first, that if you will do 20 weeks, if you do an cervical length measurement, then if there will be additional risk factors, then again repeat the scan at 24 weeks. This is the new recommendations, new one. If cervical length measurement is done, initially it is 25 mm, but there will be additional risk factors, very important, then you do previous history of preterm birth or something, then you will do again at 24 weeks. And the very important, prophylactic progesterone is not recommended for the prevention of preterm birth. Again, the statement on selected twin pregnancy. Prophylactic use of vaginal progesterone may be considered if the twin pregnancy with cervical length is less than, if it is less than 25 mm cervical length, then you go for a prophylactic vaginal progesterone. The combined strategy, you have to do a combined strategy, like you go for a physical examination indicated cercles, antibiotic tocolysis may be considered in asymptomatic between pregnancy with dilated cervix before 24 weeks. You can go for a, if there will be a asymptomatic but you physical examinations already dilated cervix, then that case you go for a cercles, physical examination indicated, antibiotic tocolysis can be started. And the cervical cercles is may be considered if the cervical length before 24 weeks is less than 15 mm, you should give cercles.